system. So as such, we have a lot of disorders that are associated with cardiovascular system. The first we are going to see is arteriosclerosis. So what is arteriosclerosis? Thickening of the blood vessel and luminal narrowing is what is called as arteriosclerosis. You have three main types of arteriosclerosis. One is arteriolosclerosis, the other one is atherosclerosis, and the last one is Myocardial medial calcific sclerosis. Myocardial medial calcific sclerosis. Okay. So arteriosclerosis, again, it is of two types: hyaline arteriosclerosis and hypoplastic arteriolosclerosis. So hyaline arteriolo, as the name suggests, it occurs in the arterioles. Hyaline arteriosclerosis is very commonly seen in benign type of hypertension and diabetes mellitus. Hypoplastic arteriosclerosis, there is a onion skin like thickening of the tunica intima, classically seen in malignant type of hypertension. Hypoplastic arteriolosclerosis can go in for fibrinoid necrosis. Atherosclerosis, as the name suggests, it usually involves major elastic arteries. Common arteries that are affected is carotid arteries, cerebral arteries, and also very commonly aorta. Okay, so most common part of the aorta that is affected here is abdominal aorta. Abdominal aorta. So in atherosclerosis, there is a accumulation of fat, accumulation of lipid-laden foamy cells along with extracellular matrix in tunica intima, which is going to block the lumen of the arteries, leading on to ischemia, which in turn can lead to death, that is infarction. So this atherosclerosis can go in for all these changes. The last one is Myocardial medial calcific sclerosis. It is a dystrophic type of calcification which occurs in medium-sized muscular arteries. They are rarely occlusive and usually they are an incidental finding where you have calcific deposits that is occurring in the tunica media of the vessel wall. Calcific deposits occurs in the tunica media of the vessel wall. Coming to the calcification, a small point. So calcifications can be of two types: metastatic calcification and dystrophic calcification. So metastatic calcification occurs whenever there is abnormality in calcium metabolism of the body. They usually occur in living cells of the body. Mitochondria is the first organelle while calcium deposits are occurring inside the cell. Common sites for occurrence of metastatic calcification is gastric mucosa, kidney, lung, systemic arteries and pulmonary veins. Whereas D for death. Dystrophic calcification occurs in dead tissue. Here the calcium metabolism is almost always normal. Characteristically it occurs in TB lymph node, any abscess site or even any bicuspid aortic valve and so on. Okay, so that is about a small note about calcification. So coming about arthritis. Arthritis is also called as vascular or arthritis, as the common name suggests, is vasculitis. So what is vasculitis? Vasculitis is inflammation of the blood vessel wall. Inflammation of the blood vessel wall. Again, vasculitis of many types classified based upon the blood vessel wall. The most important arthritis are giant cell temporal arthritis. Okay, so giant cell temporal arthritis, important points regarding that. The most common artery that is affected is superficial temporal arteries. The most characteristic clinical finding is patient presents with unilateral pulsating headache. If it affects ophthalmic branches, they can have visual disturbances. That is, and you have a segmental granulomatous inflammation. It is a segmental granulomatous inflammation. And then is Takayasu arteritis. As the name suggests, it is called as pulseless disease. Important point, it affects the great tributaries of the arch of aorta. Great tributaries of arch of aorta. Next most important point is polyarteritis nodosa. Remember, it involves medium-sized muscular arteries. It will not involve arterioles or capillaries or venules. It will not involve pulmonary blood vessels. It will not cause glomerulonephritis. It is associated with the presence of HBsAg antigen. There is fibrinoid necrosis occurring in polyarteritis nodosa. All the polyarteritis nodosa will be in contrast with points from microscopic polyangiitis. So remember, they will affect arterioles, capillaries, venules. They will affect pulmonary arterioles. They will produce glomerulonephritis. They are not associated with HBsAg antigen, and they are more commonly associated with drug-associated vasculitis. Next important topic we are going to see about heart is myocardial infarction. So what is myocardial infarction? It is the death of the myocardial tissue because of the lack of the blood supply. The most commonest cause of myocardial infarction is thromboembolism. Okay, so myocardial infarction as such, it's of two types: transmural myocardial infarction and subendocardial myocardial infarction, and also you have microinfarctions causing multifocal infarctions in various areas of the myocardium. So myocardial infarction, the light microscopy changes will occur only after 4 hours of infarction. The first microscopic change that is seen in this is waviness of myocardial fibers. The first gross finding of myocardial infarction will occur after 12 hours. So less than 12 hours, if you have to identify MI area, it can be done using TTC dye test. So granulation tissue in myocardial infarction appears at around 7 to 10 days of MI, and scar tissue will appear at about 2 months of myocardial infarction. The most prominent enzyme that is raised and most sensitive enzyme that is raised in myocardial infarction is myoglobin. That is the most specific marker for myocardial infarction. Right. So next we are going to see is rheumatic heart disease. So rheumatic heart disease is because of infection with beta hemolytic group A streptococcal bacteria. So what are the important morphological changes that can occur in heart due to rheumatic heart disease? We have the development of Ashkoff body, which is due to fibrinoid necrosis of collagen bundles that is present in the myocardium. You have McCallum patch that is present in the left atrial valve. We have the development of vegetations that are present in the atrioventricular valve. Most common valve that is affected here is mitral valve. In late stages of the mitral valve involvement, the valve will be called as fish mouth valve or buttonhole deformity. And these vegetations can get infected and can predispose to the development of infective endocarditis. Again, vegetations can occur in the heart in 4 main conditions. So first is rheumatic heart disease, where you have small, warty, firm vegetations seen along the line of closure, that too in the atrial surface. So that is a rheumatic heart disease vegetations. Then you have a marantic endocarditis, usually seen in patients with disseminated intravascular coagulation, cancer patients, cachexia patients. You have the development where you have small, warty, friable vegetations. So here embolism of these vegetations is very rare, whereas here they can emboli and they are also present in line of closure. The next vegetations we can see is Liebman Sachs endocarditis, where you have flat, friable vegetations. See, these are all sterile vegetations. RHD vegetations are sterile, marantic vegetations are sterile, and Liebman endocarditic vegetations are sterile. That means they don't carry any microorganisms. Here the vegetations are seen in both sides of the valves. Okay, very commonly seen in patients with systemic lupus erythematosus. And the third type is infective endocarditis. So what is infective endocarditis? It is actually microbial invasion of the endocardium of the heart. Microbial invasion of the endocardium of the heart. Again, it's classified into acute endocarditis and subacute endocarditis. In acute endocarditis, valvuloplasty will be the most commonly used treatment. It won't respond to your IV antibiotics, whereas subacute usually it responds to IV antibiotics. The commonest cause of acute infective endocarditis, Staphylococcus aureus, that is the commonest agent causing infective endocarditis. Again, the commonest agent causing infective endocarditis in IV drug abusers is again Staph aureus. Commonest cause of infective endocarditis in people with prosthetic heart valves, it is Staphylococcus epidermidis. Again, culture negative infective endocarditis is caused by a group of organisms called HESEC, Haemophilus aprophilus, Actinomycetomatous actinobacter, Cardiobacterium hominis, Eichinella and Kingella kingae. Whereas the commonest cause of subacute infective endocarditis is Streptococcus viridans, and subacute endocarditis following tooth extraction is caused by Streptococcus mutans. In infective endocarditis, the vegetations are very friable. They have areas of necrosis, they are areas of hemorrhage, and they can easily undergo emboli. In other ways, the vegetations are septic in nature as they contain bacteria within them. So that is about the various vegetations you can see in the case of valve deformities. Then we are going in for cardiomyopathies. That means disorders exclusively associated with the myocardial tissue of the heart. So we have hypertrophic cardiomyopathy, we have dilated cardiomyopathy, and you have restrictive cardiomyopathy. In hypertrophic cardiomyopathy, there is asymmetrical hypertrophy of interventricular septum. So here there is a reduced compliance of the heart to receive the blood. So this is a diastolic dysfunction disorder. It's a diastolic dysfunction disorder. In dilated all the 4 chambers of the heart are dilated. Most commonest causes alcoholic cardiomyopathy and postpartum period. And also drug-induced, especially doxorubicin and daunorubicin can cause this dilated cardiomyopathy. Here the heart cannot contract properly, so it is an example of systolic dysfunction. And in restrictive cardiomyopathy, again the compliance of the heart is reduced because of accumulation of products within the heart, classically seen in glycogen storage disorders, endomyocardial fibrosis and so on, where the heart will not receive the blood. That is about restrictive cardiomyopathy, which is a diastolic dysfunction. Again, remember the commonest benign tumor of the heart. The commonest benign tumor of the heart is myxoma. It's a myxoma which is very commonly seen in the left atrium. So it's also called as left atrial myxoma, and the syndrome associated with this left atrial myxoma is Carney syndrome. The most commonest malignant tumor of the heart, or the most common tumor of the heart that is present in children, is rhabdomyosarcoma. Okay, so that is about the tumors that are affecting the heart. Then we are going in for respiratory system. So what is the most common disorder that are seen in the respiratory system? So the most common disorders, or the parenchymal disorders of the heart, are your pneumonia, where there is a bacterial involvement, and also chronic obstructive pulmonary disease. So again, the disorders of the heart, lung, as broadly classified into obstructive disorders of the heart, lung, and restrictive disorders of the lung. So what are the differences between this obstructive and restrictive disorder? In obstructive disorder, you have inspiration is normal, expiration is difficult. They will not be able to expire the inspired lung. So the lung will be very voluminous in the case of obstructive lung disorder. So total lung capacity will be increased, residual volume will be increased, whereas forced expiratory volume will be reduced in the case of obstructive lung disorder. Whereas in restrictive lung disorder, the patient will have reduced compliance. That is, the lung will not be expand to receive the air. So the total lung capacity will be reduced in them. Residual volume or vital capacity will be reduced in them, whereas the forced expiratory volume or 1 second or time to vital capacity will be normal in the case of restrictive lung disorder. The most obstructive disorders are commonly called as COPDs, or chronic obstructive pulmonary disorder. The 4 prototypes of these disorders are emphysema, chronic bronchitis, bronchiectasis, emphysema, chronic bronchitis and bronchiectasis. Whereas here it's classically called as, there are so many disorders like pneumoconiosis, which is exposure to inorganic substances. You have hypersensitivity pneumonitis. You have disorders because of connective tissue disorders leading to restrictive pattern, and autoimmune disorders of the heart, which can lead on to this restrictive pattern. Okay, so coming on to the emphysema. So what is emphysema? Abnormal enlargement of the alveoli is what is called as emphysema. So again, you have 4 main types of emphysema. You have centri-acinar emphysema. It most commonly affects the upper lobes, most commonly seen in smokers. You have pan-acinar emphysema, most commonly occurs in lower lobes, seen in alpha-1 antitrypsin deficiency patients. You have distal or para-acinar emphysema. which is very commonly seen in upper lobes associated with scarring, and you have irregular emphysema which can occur anywhere, and the most commonest cause of pneumothorax. And in chronic bronchitis, it's mostly a clinical disease rather than a pathological identification. Reed's index is elevated in the case of chronic bronchitis. And the next COPD is bronchial asthma. So in bronchial asthma, the sputum will have characteristic findings like Crayola bodies, which is the denominated epithelial cells you can see, and Cushman's spirals. Remember, oxygenation is well maintained in the case of emphysema, so they are called as pink puffers, whereas in chronic bronchitis, oxygenation will go off early, so they are called as blue blotters. Whereas bronchiectasis, it is due to abnormal permanent dilatation of the bronchi because of frank separative infections. Patients who have got disturbances in the ciliary motility like ciliary dyskinesia, situs inversus, they are more commonly prone for bronchiectasis, and bronchiectasis patients are more prone for the development of secondary amyloidosis, bacteremia and septicemia. A small note about amyloidosis. So amyloidosis, it is the accumulation of abnormal protein in between the cells. You have many types of amyloidosis: primary amyloidosis and secondary. The only primary amyloidosis is AL amyloid, seen in the case of multiple myeloma. Rest are all considered as secondary amyloidosis. So you have AA amyloidosis or secondary amyloidosis or reactive amyloidosis, which is seen in long chronic disorders like reactive rheumatoid arthritis, reactive arthritis, lung abscess, syphilis, and so on. We have A beta amyloid, which is seen in the case of Alzheimer's disease. We have beta 2 microglobulin amyloid, which is seen in patients with chronic hemodialysis. You have ATTR amyloid, which is seen in patients with familial amyloidosis. You have ACAL amyloid, which is seen in the case of medullary carcinoma thyroid. And again, amyloid can be detected using special stains like Congo red. With fluorescent microscopy, it gives a apple green birefringence. Then coming to pneumoconiosis. So pneumoconiosis is because of chronic inhalation of inorganic particles in the air. Again, the most common pneumoconiosis are co-workers pneumoconiosis, which usually affects the upper lobes of the lungs. And then you have asbestosis because of inhalation of asbestos fibers. Here you can see the asbestos bodies engulfed within the alveolar macrophages, which are called as ferruginous bodies and asteroid bodies. And asbestosis patients, if they are smokers, they are more prone for the development of bronchogenic carcinoma. Asbestosis as such can cause mesotheliomas, and it's also associated with the development of CA colon. The next one is silicosis, affects the upper lobes of the lung because of inhalation of silica dioxide. Here, eggshell calcification can be noted in the upper lobes of the lung. Again, inhalation of the cotton will produce byssinosis. These are the terms given for the Inorganic inhalation, and inhalation of jute will produce bagosis. Inhalation of this sugarcane fibers will produce farmer's lung or Hayes disease. Farmer's lung or Hayes disease. And inhalation of feces of birds, in the case of you have bird fanciers disease, and you have cirrhosis, okay, tanosis, and so on according to the inhalation. And then you have one more common term, pulmonary alveolar proteinosis, where the patients have anti-plasmodium CSF antibodies. So there is reduced removal of surfactant protein, leading on to destruction of alveoli, Okay. So next we are going in for pneumonia. Again, pneumonia can be classified into two types. You have lobar pneumonia and you have bronchoalveolar pneumonia, which is a patchy consolidation of the lung. The commonest cause of community acquired pneumonia is Staphylococcus aureus. The commonest cause, sorry, it's not Staphylococcus aureus, it is Streptococcus pneumonia. It is the commonest cause of community acquired pneumonia, followed by H. influenzae. The commonest cause of nosocomial pneumonia is Pseudomonas aeruginosa. The commonest cause of pneumonia in patients with cystic fibrosis, again, is Pseudomonas. The second commonest cause is Staphylococcus aureus. The commonest cause of pneumonia which can lead on to lung abscess is Klebsiella, followed by Staph aureus. Pneumatoceles is very commonly seen in the case of Staph aureus infection. Pneumonia in chronic alcoholics and in diabetes mellitus patients is most commonly caused by Klebsiella. Atypical pneumonia is very commonly caused by Mycoplasma pneumoniae and Legionella pneumophila. So that is about pneumonia. Then we are going in about tumors of the lung. Again, we have very many important tumors of the lung. First one is squamous cell carcinoma. It is a central tumor, most commonly shown in smokers associated with p53 mutations. The tumor will show what is called as keratin pearls, and most common paraneoplastic syndrome we can see in this patient is hyperparathyroidism, leading to hypercalcemia because of production of parathormone related hormone. So the next one is adenocarcinoma of the lung. It is the commonest type of cancer that is seen in both males and also in females. Very common in people with non-smokers. It is a peripheral type of cancer associated with KRAS mutation. Next you have, one of the important variant of the adenocarcinoma is your bronchoalveolar carcinoma, which is arising from the type 2 pneumocytes or Clara cells, where the tumor shows a lipidic type of growth or lipidic pattern of growth. Okay. So next is your small cell or oat cell carcinoma. It is the most malignant variety of lung carcinoma. The cells will show a salt and pepper pattern of appearance. It is also associated with KRAS mutations. It characteristically produces secondary metastasis in adrenals. The tumor cells show azopardy effect, and the most commonest paraneoplastic syndrome that is seen in these patients is Cushing's syndrome. And the last one is large cell adenocarcinoma of the lung. So small cell or old cell carcinoma produces the most abundant and prominent of paraneoplastic syndrome.